and get started. And we ended off with page 115 and 116 as we talk about continuous supervision. I think I need to go back. And I wanted to discuss with you incidents and accidents as it relates to how supervision to prevent accidents and what your requirements are. Residents who are falling all the time, residents who have had a decline, and your staff are recognizing a decline, and they fall, and they fall, and they fall, and what are you doing about it? Residents who have multiple falls, and each fall has worse outcomes. Maybe they have a scratch today, but the next fall, similar circumstances occur, and maybe it's a deeper scratch, and then the next fall, maybe it's a broken hip. What did you do? What kind of supervision did you provide to that person? What did the personal care home actually do to prevent the accident from happening? How many of you, when a resident falls, actually conducts an investigation to identify what caused it? Raise your hand if you do. Okay. If you don't, it would be a good idea to start investigating it. And not just, oh, well, she was trying to get up to go to the bathroom. It was 2 o'clock in the morning. But why was she trying to go to the bathroom? What caused, was she trying to go to the bathroom at 2 o'clock in the morning because she normally goes to the bathroom at 2 o'clock in the morning and you normally have a staff person to assist her getting to the bathroom? Maybe she has some gait issues where at nighttime only she's not sure-footed. That's all part of the assessment process that your facility needs to be doing. If persons are falling on a regular basis and you're not identifying what causes it, how are you going to know what to intervene with? And are you assessing to determine the interventions that you put into place, are they effective? Yes, we understand that you're strictly a licensed personal care home, that you're not a skilled nursing facility, but you also are required to provide continuous supervision to ensure and monitor the residents to ensure that the residents' health care needs are being met. If residents are falling all the time and you're not implementing interventions to prevent continual falling, how are you assuring that their health care needs are being met? Maybe it could be as simple as there is a cognitive status change. It could be that that person now is having to go to the bathroom more often than before. Maybe the doctor put that resident on a diuretic, and that diuretic is causing that resident to need to go to the bathroom more. Maybe they're having visual impairment. It's dark already, it's nighttime, the lights are out, they go to get up, and normally it's fine for them to get up and go to the bathroom at 2 or 3 o'clock in the morning, but maybe their visual impairment is impeding them. It's more difficult for them to see, and that's when they need more assistance. So you have to take a look at that. You've got to look to see, are their shoes fitting well? How are they falling? When are they falling? Why are they falling? Because it is still your responsibility to provide supervision and monitoring of those residents, and to identify what caused it. Are you always going to figure out what caused the fall? Can people just fall? Honey, I do it every day. I trip on my own feet, don't pick my foot up right. I'm an accident looking for a place to happen. That's what my mom has always told me. She thought that it was funny because as a kid, I would trip over things. Then she told me to watch where I was going. Look down. Watch your feet. Well, then I hit a pole. So then she said, well, look up. Well, then I trip over something. So, and as we all know, through the aging process, our abilities, and they decline. And we're less agile than we once were. So, it's unfortunate. It happens. We're all getting there. So, but those are things that need to be considered. Incident accidents not only includes falls that occur. It also can be that incident that occurs when you actually did have to restrain somebody. And when you restrain somebody, how did you make sure that it was a benefit rather than a risk? Did a staff member actually take a cord and tie that resident's hands to their chair so that they wouldn't scratch themselves? Like Jerry said earlier, things are done with good intentions and ignorance is bliss. However, when actions are determined based on ignorance and negative outcomes result, like a resident trying to get out of a restraint and hanging themselves, or maybe your staff thinks that the side rails are a good thing. It helps them turn and reposition in bed. How many of you all have side rails in your facility? Any? Oh, I like it. Only one has side rails?
Oh, no.
No? So if you have side rails, that's a consideration. Is it a restraint? If you have, how many utilize reclining chairs? Anybody have reclining chairs in their facility? Yeah? How about a lift chair? Anybody have lift chairs where the family brought a lift chair in? Okay. Lots of issues can happen with reclining chairs. A reclining chair, if someone can't get themselves up and out of that chair, is it a restraint for them if they can't do it themselves? Is your staff person going over there and saying, hey, let's get you seated, and they sit them down and then they cock it back, the legs are up in the air, they're leaning back and they're ready to rock and roll to a nap. But they try to go and get up, they can't get anybody to come and help them. It's in that locked position with their legs up. It's a restraint for them. Then they try to get up out of that chair, do the best they can, they fall out, possibly break a hip. So every action may have a positive reaction or consequence or a negative reaction or consequence. We've recently cited citations, and I'm not being specific to a personal care home, but if you have these devices in your facility that are considered assistive devices, you have to be aware that the potential for them to be harmful if you don't assess them for appropriateness for those residents is always there, and that being the lift chair. Is the lift chair appropriate for that individual? Well, Aunt Nancy brought it for her. The family was determined they had to have this for her in the facility because it helps her get up. That assistive device is good to help them get up when they're able to get up safely in a safe manner. They hit the button, then it shoots them out, and they're shot put across the room. Maybe they have vertigo going on. They've got a little dizziness. So as soon as they come up to rise, they're not steady on their feet and they fall. Maybe the resident is an above-the-knee amputation, and they only have one leg, and they're using this wonderful assistive device to help them rise. And your staff it does help them to be independent because it can help them to come to rise. So we're not saying you can't use these devices. What we're saying is be aware, make sure you assess it for the appropriateness for these individuals so that you can prevent incidents and accidents. And as your residents progress towards more decline, that sounds horrible, progress towards more decline, as they continue to decline, reassess those wonderful assistive devices that you utilize in order to prevent possible incidents or accidents. But they are accidents, some of them are, but you're also held responsible for negative outcomes if you don't do the appropriate assessment to identify the problems, to identify the causal factor. Supervision of self-administration of medications. If you have residents who are actually doing self-administration of medications, you want to make sure that they're appropriate to do self-administration of those medications, right? They need to know what their medications are that they're taking. You've got to make sure that they're appropriate for that. But the main issue here is we are seeing lack of supervision that has occurred in personal care homes from the standpoint of elopement, where the resident gets out, falls resulting in serious injuries, head traumas, broken hips, and in other states, not just ours, people who had eloped who were found dead only 3 blocks away, but it took them several weeks to find that person. And that person was stuck between a barn and a fence. So it's not just happening in Kentucky, it's happening nationwide, where, they want to get out. They're going to find their way out. We have little Houdinis, and we're trying to provide care for them. And I think when you're aware of those opportunities, that if you see someone wanting to get out of something, maybe it's time to take a look at it again and see if that's still appropriate for them. If you have a resident in your facility who's in one of those motorized scooters or wheelchairs, are they still appropriate to be in that? Something to consider. Are they wreaking havoc upon other residents? Is it that mean old grandpa who was mean before he got the scooter and now he's still mean while in it? And he's running people down. Things do happen. But we want you to be aware of these things, that it is your responsibility to continue the assessment process throughout, to develop what actions and interventions that you and your staff are going to put into place. Jerry talked about all 3 shifts. This is a 24-hour facility, right? And even if you have that one person and you only have 1 floor, and you notice it said that they have to be awake, okay? So no snoozing, but they have to be awake. You have to make sure that every person knows and is aware of how to care for each one of those individuals, even if you're just meeting that minimum requirement of 1 person awake at night. Okay? They are still responsible to know what interventions that you have set out as the administrator of the facility, because the responsibility of your facility lies on the administrator. Every person in that facility is the facility, however. If they do a negative action, the facility can be determined in noncompliance and deficiencies can be cited. So I think the moral of the story that we've been trying to carry out throughout this morning and leading into this afternoon is it is your responsibility. You've admitted these persons. Even if upon admission you weren't completely aware of their social history or their medical history and background, once you become aware, you have to prove that you've done everything that you possibly can to ensure compliance with our requirements. This is one of the biggest tags that's written in personal care homes today. And I would venture to say it will continue to be because of the key aspect of continuous supervision and monitoring. A lot of people will question what is monitoring. And one of the issues that I have to say is monitoring, when you look it up in the definition, how do you monitor somebody if they have negative behaviors? How are you teaching your staff to monitor, and do they know that they're monitoring, and for what? Monitoring is watching, keeping account of, knowing how often it's happening, what is being done. The interventions that you put into place, are they effective? Are they working? Does this intervention only work at night and not in the morning? Because as we know, that aging progression, things happen, especially for persons who are diagnosed with dementia of Alzheimer's type with sundowning. So just remember, it is your responsibility, continuous supervision and monitoring. Is there any example that I left out that we wanted to discuss? Okay. And to continue on, we'll go to P116. All personal care homes shall meet the following requirements relating to the provision of basic health and health-related services. The person in charge of the facility shall be responsible for obtaining medical care by a licensed physician promptly in cases of accident or acute illness of any resident. Such instances shall be recorded in the resident's medical record. I can give you a great example. A resident falls, starts walking differently, starts complaining of pain. Let's just throw out a date. Fell on October the 1st. Complains of pain. But it's not continual. So they'll give them a little aspirin. It's one thing they're able to give them. Never contact the physician. Continues to complain of pain. This is October the 5th. Stops eating. Continues to complain of pain. No big deal. It's not constant, the facility says. He didn't constantly complain of pain. Continues to not eat. Starts losing weight. Complaining of pain. Finally, somebody notices that he's limping severely with that one leg. Still complaining of pain. 2 weeks later, they finally send that resident out. The resident had a hip fracture. They didn't make sure that there was prompt medical care. They didn't notice the signs and symptoms. It requires prompt medical care. And the administrator, the person in charge of that facility, at night, even if it's third shift, that person in charge of the facility is responsible for obtaining medical care for those individuals. And to make sure that if a fall does occur, that the people who are in your facility are able to take action and know what your policies and procedures are when an event like that happens, and can determine the appropriateness for what kind of care has to be provided. P117, medications or therapeutic services shall not be administered or provided to any resident except on the order of a licensed physician or other ordering personnel acting within the limits of their statutory scope of practice. So basically what that means is I'm not a licensed physician, so I can't order medication. I'm a licensed nursing home administrator, but I still can't order medications. So I can run a nursing facility. A licensed nurse can't order a medication. They can administer a medication. They can write down an order, but the doctor still has to write the order, right? Unless you're a nurse practitioner with that authority. Administration of all medications and provision of therapeutic services shall be recorded in the resident's medical record. And that just proves that you have the documentation to support what you're doing in your facility. P118, telephone orders. If orders are received by telephone, the order shall be reported on the individual's medical record and signed by the physician or other ordering personnel acting within the limits of their statutory scope of practice within 14 days. Not 14 work days. It's 14 calendar days. Of course, for you all, every day is a work day because you're operating 24 hours a day. But it's within 14 days. 119, accidents and incident reports. We're hammering this down, aren't we? Accidents and incidents. So, a written report of any incident or accident involving a resident, including medication errors or drug reactions, visitor or staff shall be made and signed. Visitor or staff shall be made and signed by the administrator and any staff member who may have been witness to the incident. The report shall be filed in an incident file. There's a typographical error on there. I didn't catch that one. One thing that's important, when we come out to conduct our investigation, let's say we got a complaint. Ruby Joe has fallen in the facility 4 times, and this last time was the end-all be-all. She had a hip fracture. She's now in the hospital. She had to undergo surgery, and she'll never be able to go back to that personal care home. When we come out to conduct an investigation, we're going to take a sample of residents based on the information that you provide us. We're going to look at number of residents who have a risk for fall. We're going to look at the incident reports that you all had on residents who've fallen. we're going to ask you, not necessarily for your incident report, we're going to also ask you for your investigation that you conducted to determine what the causal factors are. And then, what did you do? After this resident had 2 or 3 falls, what did the facility put into place? Okay? So, don't be surprised if we come out on a complaint investigation, or if we do a standard survey for relicensure and identify that there's a whole bunch of people falling in your facility, and we pull a sample of residents and we ask you for information and what your investigation identified and what you did with that information, and then how you followed through with it.
I have a question.
Yes.
What on falls? What do you consider a whole bunch of people? Everybody has the potential to fall any given day. You fall every day.
You're right. And you're Wonder Woman. I'm going to grow wings and fly. Well, when we do a sample, you're right. People have the potential to fall every day. And we're not saying that you can't have falls in your facilities. What we're saying is, when we conduct a tour to identify which residents we're going to pick up in a sample, we're going to try to find out what is going on in the facility. Are there a lot of residents who have been falling? It could be that maybe your facility is only a 20-bed licensed personal care home, but 20% of the people we talk to have had multiple falls in a short period of time. Well, 20% out of 20 beds, that's a pretty big number for a small facility, and that's going to be a concern. So we'll probably look at those residents, pull a sample of those residents as being a big sample of our survey process to identify if there is a concern. And just because we look at a certain number of residents who have falls, does that mean that there's deficient practice? Absolutely not. It's us going in to identify what is your process. If the resident has fallen, what action did you take? And has it stopped? Have you evaluated the effectiveness of the actions that you took? And how is that resident progressing? A fall in and of itself is not a deficient practice. Okay? But we will take a sample of residents, and we're going to look at multiple concern areas based on the information that we have in our initial tour, if it's a relicensure survey, or if we even bring in a complaint investigation. If we have a complaint that's specific to Caring Services as it relates to falls, then that will be our focus when we go in. We're gonna do a tour. We're gonna identify, try to find out how many residents have had falls in your facility. We may ask you for a list of residents who've had falls in the last 90 days, and then go from there. But the key aspect of this is a written report. That helps by having that written report, by documenting this information. It also gives you a bird's eye view, if you actually track it, to see how many times has this resident fallen. Have they fallen 10 times in the last 4 months, and it's all been between the hours of 3 and 6 p.m.? Or is it all during nighttime, around 2 or 3 a.m.? She's trying to go to the bathroom. She can't see. But did I answer your question, Wonder Woman? It's a running joke. I called her by the wrong name, so I had to tell her. I kept thinking of her as Linda Hamilton, and I thought Linda Hamilton was Wonder Woman, but that wasn't it. That was Linda Carter, so I told her that.
We know why you fall every day now.
Wonder Woman.
Another thing to think about incident reports, in looking at that, when you're tracking and trending something, you can also start to see that, you know what, we have an awful lot of falls in this particular area of the facility. So it may not end up being that the resident is actually having issues with falling related to some change in their condition, but it could be that it's actually an environmental issue. After lunch, we mopped the dining room floor. Well, the hallway outside of the dining room floor moisture gets trapped out there, and maybe that's where we're having several falls right after the noon meal in that area. So that may be something the facility can start looking at, that it's actually an environmental issue and not necessarily related to a resident or changes in their conditions. So those reports, especially when you start tracking the trending, can show you things that aren't even about the resident, but about the facility itself.
Controlled substances. P120, a home shall not keep any controlled substances or other habit-forming drugs, hypodermic needles, or syringes except under the specific direction of a physician. 121, controlled substances shall be kept under double lock in a locked box and in a locked cabinet. 122, there shall be controlled substances bound report book with numbered pages in which it's reported the name of the resident, the date and time, kind, dosage, and method of administration of all controlled substances, the name of the physician who prescribed the medications, and the name of the nurse who administered it, or staff who supervise the self-administration. 123, in addition, there shall be a recorded and signed Schedule 2 controlled substances count daily and Schedule 3, 4, and 5 controlled substances count once per week by those persons who have access to controlled substances. All controlled substances which are left over after the discharge or death of the resident shall be destroyed in accordance with 21 CFR 1307.31.
Does everybody understand what CFR is? That's a federal CFR, that's Code of Federal Regulations.
That medicine cannot be refilled for 30 days. Are we supposed to give them in?
Can you repeat the question?
Can't do it back.
Can you turn around and state your question again?
At our personal care home, most of our residents are Medicaid, most of them Medicaid. And say we filled a drug for like an arm for like a week ago, 5 or 6 days ago, and they still had quite a few left, and they got discharged home to their family by, they wanted to go home, so they go home. Do we send the drug on with them or keep it? Because I don't think their card will cover it.
I have the
If
same
they'll
question
give it
too, even if it's just insurance, they
Yeah,
won't
they won't
re-spend
refill it, will
something
they?
too soon.
And so that person's going home without their
They
name
don't
on it, without
give it to them.
Well, I'm gonna have to check into this. I know,
I called the pharmacy, they checked, was it was given.
Is the
Gabe, you have any issues?
Is it because it's a controlled substance? Because it's their medicine that they pay for?
That's what I
It's
said,
their
their card
property.
paid for it, and they can't get it refilled again, until time's up.
Our surveyor,
That's kind of the
we
issues
have
I
2 surveyors here who survey personal care homes, and they specify that it is their property, so they can take that with them. Okay?
I thought that's the way.
They would still have access to it in their home, taking that medication, even though they weren't in the personal care home.
And document it well.
Yes.
That's what we do, we would just sign out the whole pack, and I know that they're listening about it, and took men's homes.
Is that regulation included in the
It probably is not. The CFR, I think I just passed it up. Did I go too far? Yeah, I'm hitting down, sorry. But we will be posting, like I said before, we're gonna be posting all of this reg manual on our website, and we'll make sure that CFR is added to it. Okay? Yes, sir.
If you're digging for laws, you just go to AOL and put your CFR in there, and it'll give you time.
Yeah. Whether, the one thing, you can search Code of Federal Regulations on the the government website, sometimes it's hard to get right to it. Sometimes you have to scroll through a zillion regs before you get to the one, even though you put all the specific information in there. So what we can do is we can do the legwork and have that available for you on the website. And then that way you can take a look at that.
I've also seen facilities where they'll tell the family, it's not our policy to give the medication back. We return it to the pharmacist. The pharmacy gives credit for it, at which time they can go in and reorder. However, I know that sometimes the pharmacy, their credit that gets posted won't be for that month. So I'm not sure. The surveyors, I feel comfortable in what they're saying.
There's something, Jerry, with the pharmacists, they're not taking medicines.
They don't want them back.
They don't take them back. There's something that's going on with the pharmacy board that's not allowing them. So I've got some homes that are having to store this medication.
To meet federal and state laws. So if you have medications that your pharmacist is going to come by and you're going to go through this procedure and sign documents and everything, they should be stored somewhere separately. These medications also, the facility is required to make sure that these medications, even though they're not going to be used by someone else, you're also required to make sure that they are kept in a safe environment so that residents cannot have access to them and that staff aren't, well, you know, Mrs. Smith, she's gone, bless her heart, but she left behind a bunch of value. So, you know, I think that, you know, I'm having some stress at home. I think I'm going to help myself here. Why don't you have a couple too? No. Can't do that. P130 talks about if the resident manifests persistent behaviors may require psychiatric treatment, the resident's physician is notified. And Samantha talked about that a little bit earlier. When you see signs and symptoms or persistent behaviors, notify the resident's physician. I don't think this is rocket science. I think everybody understands this sort of thing. If the resident's condition does not improve enough for their continued stay in the personal care facility, the physician can initiate transfer to an appropriate facility as soon as possible. Now, I want to caution you on this. Remember, this is for the resident's healthcare needs, not for the facility's convenience. Mr. Smith is a handful. He just wears everybody out. But at the end of the day, his healthcare needs are met. He's not in danger. He's not in danger to someone else, but he just wears the staff out. That's not a reason to discharge him. So just be very careful about when you discharge a resident, make sure your physician is on board and that you're meeting what we're going to talk about later about discharge. That you truthfully can stand up and you have enough evidence that this is the reason we're discharging him, and it's not for our convenience. It is because it meets one of these criteria under discharge regulations. No restraint should be used except as permitted by, and that's the KRS 216.515(6). Restraints that require lock and key shall not be used. If there's a key involved or a lock involved, no, you cannot use them. Now, let's talk about a safety belt. If you put the safety belt on the resident in a wheelchair, for example, and then the resident says, you know, I want to get up and do this, and unlocks it and gets up, is that a restraint? If they can get up, it's not a restraint. Now, if you fix it where they can't get it out anymore, it's not a restraint. And what would be a restraint on one person may not be a restraint on another. So, you know, at this point, I could still get out of an easy chair that puts me back. But the day that I can't get out of it, it becomes a restraint. If you shut my bedroom door, I just turn the knob and walk out. I'm not secluded, which is a form of restraints. But somebody has arthritis so bad they cannot grasp the doorknob, they cannot turn it. They're actually being secluded. And you have to be very careful about that because they may ask you, will you shut my door? But then if they're in there screaming, hollering, help me, I want out, and nobody's answering it, it's actually kind of being secluded. We had a very unfortunately sad situation where the staff were very frustrated with dealing with an MR resident, and so they put Vaseline on his doorknob. and he could not, his motor skills were very poor, he could not get hold of it to turn it. They felt that was humane and explained it away to us that, well, we didn't want to lock him in because we were afraid that would get us in trouble with the fire marshal. But we just couldn't have him running up and down the hallways, interrupting and smacking people and doing all these behaviors. So he put Vaseline on it, and that way he just sat there over and over and over. That is a restraint, and it's cruel. That's just mean. So regardless of why it's done, it is a restraint. So those are things to think about. And I don't think that somebody sat at home one night and said, how can I make this resident's life awful? But I think it was a quick response that they thought was a good idea, which was not. Part of that was lack of understanding of restraints, resident rights, and truthfully, what facilities and policies are. Because I guarantee you, this facility had no policy that said that was acceptable. So be very aware, like I said, sometimes staff, through misunderstanding, poor education, or frustration, do sometimes silly things. So, then that kind of leads into the next thing. Restraints shall be applied only by appropriately trained personnel and shall not be used as punishment, discipline, or convenience for staff, or as a mechanism to produce regression. And that's kind of really dating us. That goes way back, where restraints sometimes were used to actually bring out anger in people for therapeutic reasons, which since then have been proved to be very inappropriate. So just be very careful about restraints and how they're used. And make sure, if a restraint in any way, shape, or form, whether it's something ordered or something somebody did inappropriately, that you really have lots of documentation to let everybody know who may be interested in that know exactly what happened. Each resident shall have an annual medical evaluation by a physician. Annual, everybody understands the definition of annual. That's, if not, it's, like I said, the dictionary will give you that. And the dictionary defines annual not as 366 days. 356 days. So we need to, 366 days, I got it. So when you look at that, where somebody says, oh, well, I know it's annual, but it was just one day off, I have to go back to the definition. And I know that people are like, man, he is tough. But I mean, it's pretty clear. You've got 12 months to do it. Don't take 12 months in one day, okay? So make sure it's done. Sometimes there are extenuating circumstances. You set up a physician's appointment for somebody, or their family says we'll do it. They do it. The doctor doesn't get you the information. It gets canceled. Then he's sick. He can't go. I mean, lots of things happen. So I probably wouldn't wait till a week before the year is up. Probably maybe do that a little bit ahead of time, because as you all know, if it can go wrong, if something will happen, it will happen. So, and then the results of that evaluation has to be recorded in the resident's medical record. And that's the other thing. You don't want the results coming back after they've been there for more than a year, or on their annual evaluation, coming back saying they have TB. And then, because the first thing that's going to happen is, why didn't you not get this within that annual amount of period? So that you would know this, or something else. The resident, and this happens a lot too, this is the minimum standard. The doctor can require, I want this resident to have a checkup every 3 months or every 6 months because of issues with cancer or issues with colon, whatever it may be, blood pressure. And then the facility doesn't follow those physician orders, and then something happens. We've had records where the physician said, I want to see this patient in 3 months. I also want to be notified of blood pressure checks taken ever so often. And if blood pressure rises above this amount or whatever I need to know, the facility didn't do it, the resident had a stroke at the time. So then we look at the facility and say, you didn't follow the physician's orders. It's possible, had those orders been followed, that resident may not have had that stroke. Their medication could have been changed. I mean, anything's possible. At the same time, it may not have, but there's no way the facility has a leg to stand on because they didn't follow the physician's orders to start with. Any resident or prospective resident that is known or suspected to have a communicable disease, in which there's a reasonable probability of disease transmission exists in a personal care home, the facility administrator shall assure that a physician is contacted and the appropriate measures are taken on behalf of the resident with the disease and other residents in the facility. So if you have a resident that's discharged from your facility for whatever reason, and then it comes back to you a week later that there's a possibility they had TB, there's a possibility they had some transmittable disease, the facility needs to be taking some sort of action. Physicians need to be notified. Perhaps residents need to have tests, or at the very least, you need to be watching residents under physician's guidance for signs and symptoms of something. So, but that should be something that you document, that you have very clear and concise information on as to what you are doing, and staff need to be very much aware of that. And I get calls from facilities saying, you know, we've had a gastrointestinal issue. We notified the health department. We have 10 people that have come down very sick with this. The physicians have been notified. Right now, we're limiting access to the facility by requesting family members not visit if they don't have to. We've done an increased hand washing and monitoring, and we're in guidance with information the health department's asking us to do. That's all. That's wonderful. That's what the expectation would be. And then usually within a week or two, I get a phone call from the facility. Everything's back in order. We've had a decline in people being sick. Well, actually, right now we don't have anyone. So whatever the issue was, they got taken care of. So if it lingers and it continues to go on and on and on, there's a problem there in the facility that you need to get to the bottom of. So those are things that it's very important that you have policies and procedures ready, because it can happen any day. I mean, tomorrow, you know, knock wood, it doesn't happen. You could have an outbreak of swine flu in your facility. Are you ready for it? And you can be ready. You may not be able to prevent it, but you can be ready and have measures in place of exactly what you're going to do. Resident care services. A personal care home shall provide residential care services to our residents, including room accommodations, housekeeping, maintenance services, dietary services. These are pretty basic stuff. If you're going to provide care to people, you're going to have to keep their rooms clean. You're going to have to feed them. You're going to have to take care of broken items. Be very careful. Some facilities, I know there's not a lot of money out in personal care. Nobody's getting super rich. But the facility has to be maintained in what's considered a reasonable standard. So if you have a piece of broken tile in the shower, that's not acceptable. It needs to be repaired. It needs to be fixed. If you have a piece of wood that's chipped and has splinters, that's not acceptable. If you have wallpaper that's split and peeling off the wall, that's not acceptable. Now, maybe you have paisley wallpaper and I don't like paisleys. Well, that's personal opinion. But if it's in good shape, then that's fine. That's not a problem. If your walls, the paints aren't peeling, maybe it's a color I don't find attractive, you're not going to get a deficiency because Jerry doesn't like pink paint or whatever. But you will get a deficiency if the paint's peeling, the carpet's threadbare, or it's stained. We have issues where you may have a resident that, because of recent illness, is having quite a few incontinent episodes. And maybe the furniture in your facility is not covered in the type of fabric that doesn't stain. And I walk in and I'm like, every chair, every sofa has got stains on it, dried stains. That's not acceptable. Who wants to sit in there? You know? So make sure that you do have housekeeping services that address that, because it's going to come up, it's going to happen. Or you've got somebody who picks, and before you know it, that chair arm, it's got stuffing coming out. Or just, you know, that one particular cart has got a sharp edge, and every time they go around the corner, it's knocking drywall off. You need to have systems in place. I asked the administrator, what happens? Well, we put a work order in to the maintenance guy, or to the administrator. The administrator then sends it to the maintenance. The maintenance guy then files it of importance, and then he gives it to his team, and they do. By the time it gets down there, there's 12 people it's gone through. Nobody knows what happened to it. The drywall is still messed up on the corner. So whatever your system is, make sure it happens, make sure it works. Do some QAs, send it through a dummy one just to see what happens. You know, just whatever you need to do to make sure it works, make sure it works. Make sure your facility's in good shape. It has to be clean. It has to be well maintained. Okay. Dietary services, we'll talk about that a little bit more. Basically, the facility has to provide appropriate nutritional meals for the residents. There's time frames we'll talk about between meals and snacks. And then you have to also provide substitutes. And you're not going to make everybody happy all the time. I love salt. You may have the majority of food out there is probably not going to be salty enough for me. Someone else may hate salt. Someone else likes fresh vegetables. Somebody else doesn't like things. They like everything fried. So there's going to be issues. But if you offer substitutes, what are considered reasonable foods, they meet nutritional guidelines, you've done your job. If they want to go out and get a Big Mac every single day, that's their choice. But you have to offer dietary services to the residents. Room accommodations, and this goes on to talk about that a bed has to be equipped with substantial springs, a clean, comfortable mattress, a mattress cover, 2 sheets and a pillow. And this is to keep residents comfortable. Rubber or other impervious sheets shall be placed over the mattress cover whenever necessary. Okay? So here's one of the things we need to talk about. Going in and seeing a mattress, and I do and have, and I'm sure Gay and other surveyors go out and they do pull up. I need to lift the sheets and look at the mattress. We need to see the condition of the mattresses. And let me tell you, don't let us see a mattress that has urine stains on it, that has springs popping up through the side of the box spring, that has the cording ripped and stuffing coming out. And we have seen those. When they're under a sheet, you can't tell, but we don't do all of them. But periodically, we want to see underneath the sheet. We want to see the mattress. If you have a mattress in bad shape, get it out there, replace it. You don't want to sleep on it. They don't want to sleep on it. And once it's ripped like that, you can't sanitize it. I mean, you just can't. There's no way. Beds occupied by residents shall be placed so that no resident may experience discomfort because of proximity to radiators, heat outlets, or by exposure to drafts. So make sure that you're careful about that, because we do walk in. Now, there's some thought process that, you know, if the resident is like, I am really, really cold, and I love my bed next to this heat. It's wonderful. It still has to be safe for the resident. So, depending on, and you don't want something that's going to burn somebody anyway, but it needs to be a safe situation, okay? Because you can also have a resident say, I want my window full open, and it's 2 below zero outside. You have to be reasonable. I understand you're warm. Let's find another way to cool you off. Maybe we'll get a fan, but we need to keep your window closed when it's 2 below zero. Now, if it's temperature like today, and that's not going to be harmful to somebody, and they want to keep their window cracked, if they have a roommate, we have to make sure the roommate is happy. But the facility can accommodate their needs. Now, there's just a little bit of waste right now. I think, you know, if you're heating and they're letting it go right out the window. But try to find ways to accommodate the residents' needs without endangering their roommate or making someone else uncomfortable. It's kind of a balancing act. The home should provide window coverings, bedside tables with reading lamps if appropriate. Now, some facilities may have some sort of overhead lighting system that's built in, so you would need a lamp so that the resident can read. But part of this is if at night I have a roommate and I love to sit up late and read a book, but the only light we have is the overhead light in the room, that means I can't read or my roommate can't sleep. That's not appropriate. If I have a bedside lamp that would shine so that I could read my book and not keep them up, that would be appropriate. Or if the facility has, for example, some sort of overhead lighting that you could use that's built in as part of that, would be appropriate. Now, if the resident says, you know what, I don't want a lamp on my table, take your little lamp away, that's fine. They have access to it, but they chose not to take it. That would be acceptable. You can't say, you must have that lamp. Jerry said you had to have it, so take it and enjoy it. That's not, they don't have to take it, but it has to be available to you. So if I ask them, I notice you don't have a bedside lamp. Would you like one? Yeah, but they won't give me one. We have an issue. Okay. Comfortable chairs, chest or dressers with mirrors, and a night light. Night lights are a must. Some facilities are newer, they have built-in night lights, but they have to work. Don't have burned out bulbs. If you're not a newer facility, then the little plug-in ones, as long as they work, and the rooms have them. Comfortable chairs. There's some subjective stuff there. This chair Samantha's sitting in, I don't think it's comfortable. And I would not want that to be the chair in my room. However, that's kind of subjective. You may have residents who, I think that's perfectly fine. And then there becomes what's reasonable. Well, I want a Chippendale sofa from the 1700s upholstered in this fabric. That's comfortable to me. Well, I'm probably not going to get it. But what a reasonable individual would be considered, and I think this chair would probably be considered reasonable in a residence room. If your facility wants to go above and beyond that, that's fine. But there has to be a chair. If the resident says, I'm in a wheelchair, I don't get out to get into that chair, and it's just in my way, I don't want it in here, that's their choice. But it has to be available if they do want it. Same thing, chest or dressers with mirrors and a night light. They have to be available. Now, I would have an issue if a resident says, I don't want a dresser in my room. Where do they keep their clothes? Or a mirror. I don't quite understand that either. Why would you want a mirror? I'm so ugly, I don't want a mirror in my room. Take it out. There may be some issues there. But basically, I can understand where they might not want a chair or a lamp. But these are pretty basic stuff that the facility should have available for a resident. Now, if the resident comes to your facility and says, I don't want all this stuff, I'm bringing my own furniture, and it is well constructed, it's not, you have to also look at safety. If they bring in something that's going to be harmful, there's some issues there. But let's say it's not, and they want to supply all their own furniture, lamps, things like that, that's acceptable. Be careful about mattresses if they bring their own mattress, because if it's not something that can be sanitized or it's clean, that would be an issue. Okay? Residents shall not be housed in unapproved rooms or unapproved detached buildings. So, go ahead.
One question on the mirrors. If you have private apartments and they all have their own private bathroom with a large mirror in there, is that satisfactory?
Yes, as long as they have a mirror. It doesn't have to be like in their bedroom. If they have access to it in their bathroom, it's part of their suite, you've met that requirement. But what wouldn't meet it is to say, oh, well, they have a mirror, it's down the hall in the common restroom. That wouldn't meet the requirement. Residents shall not be housed in unapproved rooms or unapproved attached buildings. Everybody gets an initial survey, and you know what rooms are considered appropriate. So I don't think we need to go into that too much. Basement rooms shall not be used as sleeping rooms for residents. So if your facility has a basement, there's a game room there, that's one thing, but not residence rooms. Residents may have personal items and furniture when it's physically feasible. You have a room that meets the qualifications of the personal care home regulations, which really and truly are not that big of a room. And I want to bring in my extra king-size canopy bed that is made from oak trees that are giant, okay? That may not be feasible for your facility. But if I want to bring in, well, this is, my bed I had at home, and it's a reasonable size, it's in good shape, I would like to have my bed. The facility can look at that, make a determination, and if you can do it, do it. Accept it, This is something personal of theirs. It will make them more comfortable. The home shall maintain clean, safe facility free of unpleasant odors. Odors are eliminated at their source by prompt and thorough cleaning of commodes, urinals, bedpans, and other obvious sources. And that basically is good housekeeping. So I want to make sure that everybody's following that. Adequate supply of clean linen should be on hand at all times. So clothing and linen shall receive immediate attention. Should not be allowed to accumulate. And believe me, I've been places where there were literally mountains of clothing, towel, sheets, and I mean the smell would. And I was like, how did this could not have been a day or 2 days or whatever. and then I get the answer, oh, the girl who does our laundry, she's been sick for a week. That's awful, and I feel terrible for her, but that's not an excuse to let the laundry stack up like this. Also, then I get, well, if we needed something, we'd send somebody down here to wash it, and that's not an answer. So, clothing and bedding used by one resident shall not be used by another resident until it has been laundered. Okay? I think that just gives me the heebie-jeebies, but just make sure that does not happen. Laundry of residents' normal personal clothing and bed linens. Residents' personal clothing and bed linens shall be laundered by the home as often as necessary. Residents' personal clothing will be laundered by the home unless the resident or their family member or responsible party accepts that responsibility. But you can't tell them, we don't do laundry. It is offered. Now, if they choose not to, and it's very possible, they may say, you know what, I know what your laundry is like. I'm not going to have Mom's good navy blue silk blouse laundered by you guys. I don't think you intentionally will ruin it, but guess what? It's probably going to ruin it. Now, I come in and say, hey, I want you to dry clean my suit. There's no requirement that you dry clean my suit. Reasonable standards. Wash my towels, wash my linens, wash my blue jeans, wash my t-shirts. Those are reasonable standards. Something that requires hand washing or, I don't even know how to clean a sequin dress, but whatever method that needs to clean the resident's sequin evening gown, you don't have to do that. You can choose to do it and have an additional fee, but that's between you, the family, and the resident, and how you plan to do that. Residents who are capable of completing their own laundry should be provided with facilities to do so. That gets a little confusing because you've also got to make sure a resident who has some confusion isn't walking down the hall and here we've got a little laundry area over here and decides, oh, I think I'll put this in the washing machine with that. Or, gosh, I think I'll take my cranberry juice and just pour it in there and see what happens. So there can be some issues with that in making a determination who can and who can't do that. And then it talks about marking personal clothing so that it's identified. Please don't do this. Some items of clothing are very difficult to mark. But the worst thing I've ever seen was to walk into a facility, and as I watch the residents walk away from me, they'll have their name backwards written across the back of the yoke of their shirt. I mean, that is really a dignity issue to me.
What if they don't want their names written in their clothes?
And there's some issues there too.
I mean, I can mine pitch and fit. You even think about it, and they're paying $4,000 a month. So, I mean, I don't want them to.
You've got to have some way to make sure.
Well, we do them individually and have them assigned a certain day at a certain time by a certain person. But
And if that way works for you, then what it is what you're doing is where it says residents' personal clothing laundered by the facility shall be marked to identify the resident. The way you're marking that could be that it's placed in a particular bag with this resident's name. Could be that is your way of marking it. Now, there may be some issues that you want to talk to your surveyor who's coming out to your facility, but you've got to prove to them, beyond a shadow of a doubt, that your method works. Because what you don't want to happen is you don't want Mrs. Smith popping up wearing Mrs. Jones' gown, and then Mrs. Smith's daughter is calling the state complaining, well, they've lost Mom's nightgown again. So, but if you can show, Gabe comes out to your facility and you can show her that this is how we mark it. It's not a literal mark on the nightgown. Because I also don't want Mrs. Smith's, if she's paying $4,000, I don't want her $100 nightgown going either.
right.
So, and then, like I said, there's dignity issues. I don't want to walk around with my name on the back of my shirt. I think that's demeaning. So there are ways to meet regulations that aren't, you have to do it this way, you have to do it this way. You can't be creative as long as it works. Because if it's not broken,